Well, I want to say good morning to you from the Florida of the Midwest. It is a blue sky, sunny, and a roasting 36 degrees. Secondly, I greet you from Barbara Brandt, the director of our center, who has visited many of your programs up in Maine, and I look forward to doing the same this fall. I apologize again for not being there, but what you see is my reading glasses, and I am now the proud possessor of 2 new artificial lenses that replace my cataracts so I can see. But I am quarantined from airplanes for another week, so that's why we're doing this by modern technology. It's been a pleasure for me to work with your team and to understand how this conference came together and what you're trying to accomplish. And I think it's really outstanding. And what I want to do in the next half hour is to kind of give you a national perspective that we see from the National Center. It is the National Center of Interprofessional Education and Collaborative Practice, but that's just too much to say, so I'm going to call it the National Center. And I'm going to go through with you the kinds of things we're seeing and we're trying to do to help groups such as yourself move into a team-based, outcome-focused model of practice. I'm not going to spend a lot of time on definitions, but these are the definitions that the National Center use that are generally regarded as good starting points for interprofessional education and collaborative practice. The operating words are in interprofessional education: with, about, and from. Learning with, about, and from each other to enable effective collaboration. This is the key to understanding what teams, interprofessional teams, particularly linked to health outcomes, are really about. This is an example of what IPE is not. This is actually parallel play in the sandbox, where a lecturer and you see people from different professions in different parts of the auditorium looking up at the talking head but not interacting with each other. So I wanted to give you some history. This comes from the University of Minnesota. And I would just say, you know, we've been at this since fundamentally almost 35 years, 40 years, when the Board of Regents decided to form the Academic Health Center of all our professional schools. And the students really came together and said, we need this because we need to learn how to work together to create new models of care and to create effective teams. And that became the reason that this Academic Health Center was formed by the Board of Regents in 1970. There's a lot of interest in interprofessional practice and education, and here's what some of the areas it comes from. There's this transition from volume to value, as has been stated by the Institute of Health Improvement, to improve the patient experience, to improve the health of populations, and to reduce the per capita cost of healthcare. Some people have created this into a quadruple aim, but the core of it is really the same. The quality and patient safety movement really did a lot, and I'll come back to this, to move this effort ahead in a model of quality improvement, which you'll hear me say is linear and incremental, and what we really need is transformative change. But the skills in that linear incremental process are actually a good start to moving into a real transformative team. The Patient Protection and Affordability Care Act has a lot in it. Regardless of how you feel about Obamacare, it is actually pushing the team interaction to create improved outcomes. New payment and care delivery models are coming. In the state of Minnesota, a large chunk of our contracted payment systems are now global fee-based or per member per month based. The accrediting bodies are all on board, competencies have been defined, and there's a major interest by patients, families, and communities in engaging in the redesign of health. And I'm not going to go through all of these trends. These are slides you can look at. This is the change from volume to value. Do we have the right group of people looking to solve the right problems? Do we really have the right workforce? Is it time to look at other kinds of members of the team beyond your physician, nurse, pharmacist, social workers, and move into occupational therapists, physical therapists, care coordinators, community-based coordinators, et cetera, et cetera. And that's the major changes that are happening in spite of the fact that teamwork is not fully understood in the context of health. And I'll spend some time on this. But the National Center believes there is sufficient evidence of the effectiveness of teams in improving outcomes in health that we should move ahead with this effort, but do it in a way that we understand what we're doing and gather the information so that we can actually begin to show a return on investment and an improvement in outcomes. The National Center actually came out of a national competition from HRSA and a group of private funders as a need to fulfill a need for a center that provides leadership, scholarship, evidence, coordination, and national visibility. Note, the National Center decides nothing. It has no pens. What it does do is it leads, it provides evidence, it provides opportunities for dialogue and interaction, and it influences the national conversation for the people with the pens who can change policy, accreditation, and fiscal policy. So the National Center vision is really quite straightforward. We believe high-functioning teams can improve the experience, outcomes, and cost of care. And we are advancing the way health workers, students, patients, and their support systems work and learn together. The important concept here that's been added is to become learning teams and learning organizations based on what you're doing so that you continuously improve and reach to achieve the outcomes that are set. So we serve as a trusted source. We're trying to change the way educators and employers work together to ensure that the graduates are prepared from the first day of work to actually be successful in the real world of the redesign of healthcare, and producing evidence of improved AAA outcomes and return on investment by interprofessional teams through data, not opinion, to identify and support adoption of best practices. Now that last bullet is worth pondering on a little, as we'll do in the rest of this talk. This is our vision. Bring education and practice back together. They got separated a long time ago, and we're suffering from it today. If we bring them together in something we call a dynamic interface or Nexus, we create new partnerships that can produce a positive impact on triple aim outcomes. So who is the National Center? Well, it's patients, families, and communities. It's learning organizations and learners. It's healthcare organizations. It's government partners. It's professional organizations. It's policymakers, what I call the people with the pens, and the thought leaders, all working together That's what the National Center is. This is not a group of 10 people sitting around in the Twin Cities. It's the whole nation coming together, working together to reconnect education and clinical practice to improve health outcomes. This is an important slide. It's about teams and becoming progressively high-functioning teams that in fact can improve health and learning outcomes. Most people start at the bottom, that getting to know each other, and it's kind of parallel play in the sandbox. Yet when you talk to everybody, everybody says, yeah, I know what teams are, I know how to work in teams. But you actually look at it, and it's like that slide I showed you before of just parallel play and not really interacting in a way that the team begins to function as a unit. A lot of people are working around patient safety and quality, and this was a clear advance, and it's had a lot of good outcomes. But it's linear and incremental. And if we are to solve the challenges of access, workforce development, community health outcomes, and drive costs out of the system on a per capita basis, we need a very different kind of team that works together in a high performance kind of way. So the trend shaping our workforce, or our work, is trying to get some standardization of what teams are, of what teams aren't, what is the right composition, how do you train them, how do you actually bring practice and education back together, what are the emerging workforce needs, I talked a little bit about that. Everybody across the nation complains about the retraining cost of the graduates of our health professional schools. And there's still an issue of many providers being able to truly work at the top of their license. There's about 20 states now that advanced practice nurses can work at the top of their license. We need role models. Bundled payments are coming in one form or another. And we're actually seeing layoffs of specialists and subspecialists around the country as the healthcare reform process moves ahead, with more emphasis on primary care, community engagement, and I should say team-based care linked to outcomes in the primary care and community setting. A lot is changing in education. This has to do with the national implementation in education at curriculum, the recognition by accrediting bodies, the system-wide connection between practice and education and its need. There's still a non-alignment of accreditation standards, even though there's an interest. And there's a mismatch with what transforming the healthcare sector actually needs with what we provide. So we're not at all convinced, for instance, that there is a workforce shortage, and think it has a lot to do with how you actually form your interprofessional teams and use providers working at the top of their license and effectively linking clinics and communities to work as units to improve the health of the population and take care of people. So what happens when practice and education leaders come together? There's growing recognition that this need is to connect education and practice at vision, leadership, and on-the-ground practice to provide credible evidence that it is in fact useful, to support IPEC leaders and advocates with a shared vision at local and national levels, and to improve the training and clinical experiences to prepare future and current health professionals. These are the competencies that were defined by the Interprofessional Education Consortium, and they're at the core of what interprofessional work is about. We're still trying to figure out what kind of tools can you actually use to assess them for their effectiveness, for how people have learned them and how they demonstrate them. But that's moving along, and we'll eventually get there. We've also identified across the country there's a need for other competencies, understanding population health, the social determinants of health, this patient-centered decision-making. Now, there are two definitions of this. One is kind of like the old lecture hall where you put the patient down at the bottom of this steep stacked group of seats and everybody looks at the patient and has something to say and hopefully has a dialogue. That's one model. That's not what we think patient-centered decision-making is about. But the model we advocate is one where the patient is actually part of the decision-making process itself about their care plan and the problems in actually implementing that care plan outside the clinic, in their communities, and in their home. Use evidence wherever possible, cost-effective practices, quality improvement and safe practice is key. Systems thinking is something that's kind of new. It's becoming paramount across the country as more and more physicians become employees as opposed to independent providers. In the state of Minnesota, almost 70% of physicians are now employed, and a critical success factor is informatics. Now, I will define informatics operationally as getting the right information to the right place at the right time to the right people to make the best decision, and then to follow up that decision and see what the consequences are and improve it if it needs improvement. This is what the National Center does. It informs, connects, engages, and advances. That's what we do in the various forms of our programs. So here's our priority initiatives. We gather data through our Nexus Innovations Incubator Network and the National Center Data Repository. We have a resource exchange, tools and training, and we're driving the national conversation. And we really need your help to do that. And I'm going to go through each one of these and kind of give you a thumbnail sketch. This is our Innovation Incubator Network, and I didn't have a chance. I should have put a line to Maine because you are now in this. And we're very happy about that, and I hope you are. And I'll explain a little bit about what this network is. The network consists of sites, each of which has one or more projects. A project is defined as having an interprofessional team that is focused on improving one or more health outcomes by working together as a team. Those are what the projects are. I'll show you some of the spectrum of them. And as that project is implemented, the National Center works with that project to capture its outcomes in the National Center's national database. That's the concept behind this. So the national database resides in the Twin Cities. It's web-based and very easy to use. So an incubator, somebody asked one day, well, what is it? Well, here's the anatomy of an incubator. It integrates clinical practice and education. It's focused on achieving an improvement in triple aim outcomes. Now, note the difference here. There's nothing in here about randomized controlled trials. That's a model that does not work. This is built upon the business model that you define an outcome you want to achieve, you put a team together to achieve it. We define it as an interprofessional team. We like to see students on those teams, and that means students and residents. And that team works together to achieve this outcome. Now, you know as well as I do, nothing goes as planned. So in moving towards that outcome, something changes. Changes in the C-suite, changes in the payment system, changes in personnel, changes in leadership. And that means you need to reconnect, change course, and we capture that in what we call a critical incident So this longitudinal data collection we follow for the duration of the process of the project. Sometimes it's 2 years, sometimes it's 4 years, and in some cases we continue to follow it because we're interested in sustainable change and whether a project can be transported to another region. We do work with agreements. These agreements are very straightforward. It says you have a project-specific database that resides in your institution. You own it. If there's any intellectual property that comes out of it, it's yours. If there's a publication that comes out of it, it's yours. We simply want to be acknowledged as a supporting organization in a publication. The data we collect is all de-identified, and it goes into our national server and in a variety of files that I'll come to in a minute. We then do aggregate analysis of the data and feed it into the national conversation for showing direction, giving insight to workforce, giving insight to payment systems, and we're very tightly connected with all the federal policy alphabet soup and funding organizations, as well as at many state levels that you see in the Incubator network. So we are interested in scalability and transportability, and that's an interesting one. For instance, we have 6 projects on care transitions, and it actually involves a common model, and we're now going to transport that to a different geography and see if it works. Here's what the National Center needs to provide information on. Does IPE-CP improve health outcomes, improve education outcomes? Does it identify the ecological and environmental factors that are essential to effectively achieve the health outcomes? Does it identify the factors essential for sustainability and transformation of the process of care? Ultimately, it's about the change in the process of care and the culture surrounding it. Does it identify the needed changes in policy, accreditation, and credentialing? And can we establish a causal link, this is an epidemiologic concept, between the educational intervention and the nexus and the outcomes themselves? That's the key piece that if you talk to the C-suites, they want to know about, and all of those stakeholders want to know about in one form or another, including return on investment. So our preliminary findings, we're actually now up to 29 participating sites in 15 states. They all have team interventions linked to outcomes. Some are focused on quality and safety. Some are focused on care transitions, disease outcomes, primary care models, and there are 3 different models that are being looked at in FQHC and non-FQHC and health system primary care networks. One is the physician MA model, the other end is the APN model, and the other is the hybrid of both of those. And they're all using similar outcomes, and there's a great deal of interest in how those function, and more importantly, the environment within they function, because I think we're already convinced, as you are, that in a rural area, you may have a very different model than a suburb or a central city urban model. And that's partly what this is about. How do we use the electronic record to automate data collection, new roles for providers, and improvements in education? So most have faculty and student training programs. We've identified these ecological success factors. If you've been in the change business, you'll recognize these right away. The C-suite inclusion, you have to see it in the strategic plan, in the budget, the support of administration, faculty, and student leadership, existing IPE programs, informatics programs, evaluation plans. These are the critical success factors. They may not be present all in the beginning, but part of what the National Center does is to help a project develop them. And that leads to our value added in site coordination, database development, so on and so forth, informatics and evaluation expertise, project design, outcome identification, because we really are moving into standardized outcomes and definitions and metrics, most of which you already use. The Resource Exchange is an online community that has all the pertinent IPEC literature. It has a repository of assessment and evaluation tools and how to use them. It has a shared information showcase. We now have what we call learning from experts with, I think it's 10 different expert areas and a national expert to communicate with. It's a way to connect with others, and we have a place to develop custom tools. What do we do to drive national change? And Barbara is in the middle of this nationwide, and some of the rest of us are out there also providing information, connecting, engaging, and advancing. So we're focused on team composition, training, functions, ecological success factors, and Nexus success factors. We direct our information at the stakeholders, and we talk about the outcomes that we're achieving. We actually have enough data in the National Center Data Repository now to begin to do the analytics and feed some of the national aggregated data into this conversation. So here are the kind of things we're working on. Engaging a significant larger number of thought leaders. We put in place a team to manage our projects with a project manager and 2 coordinators. And we're now ready to onboard another 20 sites and projects this year and another 20 to 30 a year for the next 3 years. We have figured out how to do that and how to provide the support systems. We're partnering with influential organizations like the AMA, the Institute of Medicine, the National Professional Organization. We recommend models of care and interprofessional practice and education. We know we're having an influence on policy and regulation. And we like to showcase stories of success to demonstrate the value of the Nexus. We actually believe you're already a success story, and we'd like to talk more about disseminating actually what you're doing, not only in the conference you're in, but in your statewide effort. So where do we think the nation will be? In 2020, we think we'll see high-functioning health teams are the norm. Education and care delivery systems have come together and are jointly managed at the local level. The National Center's research demonstrate what types of team work best to improve care, outcomes, and cost. Regulators and accreditors support interprofessional learning and practice. We're already working with the accrediting agencies to accomplish this. Payment models will reward quality and outcomes, making team-based care necessary for the economy of the care delivery system. And the National Center will contribute to local, regional, and national health by championing the value of integrated interprofessional education and practice. Now, I'm going to stop there and give you all plenty of time for questions. And don't be bashful. Tough questions are good questions. If you wish to express an opinion, that's okay too. If you want equal time, you will have to ask your local moderator.
Well, Frank, I'll get started. This is Dora, and ask you about, since we're here today up in the county, what we finally call the county in Maine, Richmond County, to talk about implementing clinical and professional education opportunities for students. So I'm just wondering, can you comment a little bit on the experience that you've had in other parts of the country or Minnesota, placing interprofessional teams of students in clinical settings?
Well, virtually all of our projects are in clinical sites. We don't have too many in hospitals. We only have 2 or 3 in there for very specific reasons. Most of our, in fact, 90% of our projects are based in clinics, clinic systems, and communities. So we're all on the clinical side, but we like to bring the educators and the clinicians together in the presence of students. Now, there's a variety of models, and I'll give you a couple of examples. In Western Michigan, we have an FQHC primary care clinic network that is seeing a major influx of patients because of the Medicaid influx. They're expecting about 6,000 new patients because of the Medicaid expansion. They've been using a single doc model for primary care, and they know that doesn't work anymore. So they have redesigned a team of doctor, nurse, pharmacist, social worker are the four primaries with administrative support, and they have students on those teams of those professions. And those students have defined roles in the care of diabetes patients. They are meaningful roles. We've reviewed them. And the students actually help with patient education, with medication monitoring, and work as part of the team with the patient to derive a care plan. This is one model that's up functioning. They've been collecting data for about a year. Their productivity has actually improved, and the educational outcomes have improved. And we're just getting the second round of disease-based outcomes, and we'll know that in another 3 or 4 months. So that's one model. Another model is in the Colorado project, where they are actually beginning by training students with team steps and faculty and practitioners with team steps, and they are going to work together for quality improvement outcomes. And this they did with some trepidation, and I think you probably know that most quality improvement programs across the country do not include students. There's some fear that the students will dilute the outcome. So Colorado is already showing that that's not the case. And in fact, the inclusion of students improves outcomes, and that you can learn a lot about how you actually train teams. And they are now going to use this model to step it up that ladder to look at different kinds of health outcome improvements. They've identified areas of cost reduction that they can get. They've identified areas in care transitions that they can improve. And that brings me to the third model, which is the care transitions model. And I'll give you one example. It's in the state of Kentucky in the stroke belt of the nation. And they now have a statewide program connecting community to the acute stroke unit, to the rehabilitation unit, to the community. It's in a statewide database and connected to a statewide education system. When they began to look at care transitions from acute to chronic or acute to rehab, they found a significant 44% patient safety error rate in that transition. Startling. They're now working with a team to understand why that is, how it can be improved, and they're beginning now to implement that model between the acute and the rehab unit, and then between the rehab and the community. So that gives you some idea that where we're working is actually in the clinical arena to improve collaborative practice by reconnecting it with educational systems. And in many of those places, they're learning what the health schools need to be teaching their students in order for them to effectively participate in the collaborative practice model when they actually get there. Likewise with the graduates of the program. Yes, next.
I got a question. Gail. Dr. Gail Brazeau, who's the Dean of our College of Pharmacy. Thank you for getting up and taking time to visit with us today and sharing your insights. So I guess you kind of led to my next question. What has the Nexus learned about how we as educators and clinicians can do as we prepare for these students to go on to these sites? What have we learned? We said that there's been some learning of essentials, because as each of our programs become more complex, with our accreditation standards requiring more IPE, we need to be more efficient. So what is the next product about what we can do to prepare students so they can hit the ground running when they go to these sites?
Good question. I'll give you some insights to what we've learned. The first thing I'll say right up front is the accrediting body for continuing education now has a joint accreditation process. So we've actually applied for that through the Academic Health Center for medicine, nursing, pharmacy, dentistry, and they will have a single accreditation for continuing education around teams. So it's all around interprofessional education and clinical practice. You can go to their website and learn about it. And the point I'm making there is if each of the health professional schools ask this question in isolation, there's no gain. That's the principal silo in the academia. And then let me explain it this way. Everybody points at medicine as the example of the Flexner model. Not true. If you study medicine, nursing, pharmacy, dentistry, public health, vet med, those are the ones I've studied very clearly. They all deploy the Flexner model. What does that mean? Well, the training of a health professional is essentially one of engramming the brain of that professional to think and act in certain ways. And none of that is to cross the professional boundaries and work with the other guy or the other girl. And you'll see that in electronic health records. So the electronic health record has simply carried the silos into the electronic system. It's very rare to see an integrated care plan. Usually there's a medical section, a nurse section, a pharmacy section, a social work section. It's usually not integrated. And that's the basis of this error rate I talked about in care transitions. There's no cross connection. So what can you do? Start communicating as a unit around interprofessional education and collaborative practice. Understand what's core to your profession that none of the other professions have, but what's shared with other professions. I'll relate to you an experience when I first became vice president. The students asked me to go to a retreat, and I went. And they were from all the schools, and they sat there, and I listened to the conversation, and they said, "Oh, do you do physical exams?" Yeah, we do. Do you measure blood pressures? Yeah. You get the idea, so on and so forth. And then they began to say, well, what's unique, for instance, about doctors? The unique core of physicians is the ability to do differential diagnosis and complicated medical decision-making. And some of that they even share with advanced practice nurses and clinical pharmacists. And it's understanding where that is and how those zones mesh so that you can actually begin to work together to do what's best for the patient. Those are my words to you, and under there are a whole lot of specific things. But if you look at where there's been success, you will see many of the characteristics you all have. Your president is behind it. Your vice president is behind this. Your deans are behind it. You've got faculty leadership, student leadership. You've got training courses. Now you need to make it happen. And the hard part is people to people and figuring out how do we do this. I used to have a rule in my office. When we went in to make a decision, the authority hat stayed on the hooks. And the important thing was getting the best decision, not who made the decision. And I would just offer that to you. It's a very different way of thinking. But when you go to value-based outcomes and value-based payment systems and integrated service lines, Those are the guidelines of success. That there's already a fair amount of data on. That's my answer.
Great. Thank you. Thank you very much. Okay. Any other questions? Okay, before we move on. Yeah, Felicity. From
just one quick question. We are south of the county. We're down in Bangor, Maine. And how do we become a site where you guys would do a site that is integrated here already and utilize the supervisors? So for those people who aren't already involved in what you're doing, how do you get involved?
The question was about trauma?
No, it was about how do people get involved who aren't already involved with the center?
That's a great question. And it has a lot to do with leadership, with your early adopters, with the development of champions, keeping an open door, continuously inviting people in to participate, finding ways for them to participate and learn about what's going on and become engaged. The critical transition occurs when you move from conversation to actual engagement. And when you see people engaging and rolling up their sleeves and focusing on the problem. So there's this old adage in culture change, which is what this is about. Keep your eye on the brass ring. If you lose the brass ring, which is your visionary landing point, you'll go off course. But if you stay focused on the brass ring and every decision you make moves you ahead, sometimes they're baby steps, sometimes they go backwards. There's an occasional leap. This transformation will occur. Everybody will be better off. And that's been the experience already where these interprofessional teams are beginning to achieve outcomes. Everybody feels good about what they're doing. They're able to support each other, watch each other's backs. They're getting paid for what they do. The patients are doing better. The community is engaged. And it's a very different kind of healthcare.
Great. Well, thank you very much for beaming in from Minnesota on this early morning for you. And we really appreciate hearing from you. And we look forward to your visit to Maine. Thank you very much.
Have a good day.